This is Usman Baber from the University of Oklahoma Health Sciences Center, and it is my pleasure and honor to be speaking to you during this virtual on-demand session during the Cardiovascular Innovations 2020 meeting. Over the next few minutes, I'll be speaking to you about 1 month of dual antiplatelet therapy as a new standard of care for stable patients. I have the following disclosures to report, which include receipt of honoraria from AstraZeneca, Amgen, and Boston Scientific. As far as a brief outline, we'll first talk about the key developments that serve as the basis for short DAPT durations after PCI, quickly summarize what current guidelines stipulate both in the US and EU, and then finally review the evidence base that supports very short and just 1 month of DAPT in relation to both patients having high and non-high bleeding risk phenotypes. So with that, let's begin and go over several key developments that have allowed us to actually have short DAPT durations in the majority of patients after PCI. The first development, of course, is the introduction and near universal use of safe newer generation drug-eluting stents. As this meta-analysis, many others have demonstrated, newer devices are associated with reductions in stent thrombosis on the order of 60 to 70%. And this, of course, translates to lower absolute risk for stent thrombosis over time. As this study demonstrates, at 3 years, patients receiving second-generation DES demonstrate stent thrombosis rates on the order of 1%, whereas those receiving earlier generation DES have stent thrombosis rates approximating 2 to 2.2%. And therefore, the introduction of these safe, less thrombogenic devices has clearly altered the risk-benefit calculus for prolonged exposure to dual antiplatelet therapy. The second important development has been the recognition that bleeding, which of course is the consequence of prolonged exposure to dual antiplatelet therapy, is associated with a significant and durable risk for mortality. This is perhaps the first and one of the clearest studies to demonstrate this fact. In this study, we can see that the mortality risk after myocardial infarction and major bleeding are not only comparable to one another, but in fact, the association between bleeding and mortality appears more durable over time, whereas the analogous association with respect to MI actually attenuates quite rapidly over time. And therefore, prevention of bleeding based on data such as these would seem to be as important as preventing recurrent myocardial infarction. The third important development that has really supported the drive for shorter DAPT durations is the fact that patients undergoing PCI in the contemporary era are a completely different case mix than those undergoing PCI 25 to 35 years ago. In these data from the Mayo Clinic, one can see that non-cardiac mortality here in the dotted line has gradually increased, whereas deaths due to cardiac causes have actually declined. And therefore, the patients who are undergoing PCI today tend to be older, more morbid, with complex comorbidities such as active or recent cancer. And therefore, it is intuitive that the toxicity of dual antiplatelet therapy may in fact be accentuated in patients undergoing PCI today as compared to those undergoing PCI 30 or 40 years ago. And therefore, all of these developments have really supported clinical trials and studies and a real shift towards shorter DAPT durations, and guidelines have really aligned to formally recommend short DAPT durations in the majority of patients. This is a nice paper that really summarizes guidelines in both US and Europe in relation to clinical presentation and in relation to bleeding risk phenotype. One can see for patients with acute MI at the bottom, there are still class 1 recommendations in the green to provide at least 1 year of dual antiplatelet therapy. However, for patients with stable coronary disease, those who are at high bleeding risk, current guidelines would indicate that there is guidance for just 3 months of DAPT duration or as short as 1 month of the 2B indication. However, stable patients who do not have a high bleeding risk phenotype, there's a class 1 indication to provide dual antiplatelet therapy for up to 6 months. And therefore, one can appreciate, in order to understand current guidelines and to make clinical decisions for our patients, we really need to understand what we mean by HBR or high bleeding risk. And it is in 2019 in this very important paper from the Academic Research Consortium that we finally have a standardized and agreed upon taxonomy to define the HBR phenotype. As one can see on the left in this cartoon, these are all the different factors that one might consider to determine if a patient has or does not have an HBR phenotype. And importantly, the Academic Research Consortium has stated that patients who have a 1 year risk of major bleeding, namely BARC type 3 or 5, of at least 4%, are those who are at high bleeding risk. So although current guidelines say that most patients with high bleeding risk should get at least 3 months of DAPT, we have evidence to support even shorter durations. So here are a handful of trials that have examined exclusively HBR patients. All of these trials examine different stent platforms, but all of them as a background pharmacotherapy only gave DAPT for 1 month. Here you can see the average age in the patients enrolled in these trials. And although these patients only received 1 month of dual antiplatelet therapy, one can see that the rate of BARC-305 bleeding was well above the threshold of 4% set forth by the Academic Research Consortium. And therefore, the fact that these trials were conducted tells us that there is certainly equipoise and acceptance on the part of clinicians, on the part of investigators, on the part of patients, and regulatory authorities that in patients who are truly at high bleeding risk, we should only give 1 month of dual antiplatelet therapy and then de-escalate rapidly to just single antiplatelet therapy. And even with such minimal exposure, we still have very high rates of major bleeding. Well, what about patients who are not at high bleeding risk? In such patients, several trials have been conducted that have really examined the utility of aspirin-free strategies. And the entire basis for why we would consider aspirin-free strategies is predicated on the notion that if we stop aspirin and continue monotherapy with a P2Y12 inhibitor, we can preserve the ischemic benefit of potent platelet inhibition, and therefore this might be a strategy we want to think about in patients at higher thrombotic risk. And at the same time, we can reduce aspirin-related bleeding. And while this has certainly been examined in the setting of atrial fibrillation, there have now been a handful of trials that have been conducted that have examined P2Y12 inhibitor monotherapy in the setting of patients who do not have AF undergoing PCI. 2 of these trials have examined clopidogrel, whereas 2 have examined ticagrelor. And in 2 of these trials on the left, you can see only 1 month of DAPT was given before transitioning to P2Y12 inhibitor monotherapy. Importantly, in all of these trials, the 1-year rates of major bleeding, BARC type 3 or 5, was only about 1.5%, and therefore these trials really enrolled non-HBR cohorts as articulated by the Academic Research Consortium. And therefore the application of aspirin-free strategies with respect to these clinical trials really should be conditioned on those patients who do not fulfill the HBR phenotype. The Global Leaders trial was the first one, examining ticagrelor and aspirin for 1 month and ticagrelor alone compared to standard DAPT in a large clinical trial. And although this trial was negative, the important insight from this trial was that when we withdrew aspirin after just 1 month of DAPT, irrespective of how patients presented, as seen here in the forest plot, there was certainly no penalty to be paid. So although we got no benefit with respect to TCA monotherapy in this trial, the important finding is that there was no penalty to be paid when aspirin was withdrawn. The STOP-DAPT-2 trial, in contrast, examined patients receiving clopidogrel alone after 1 month. And again, on the ischemic side, you see no penalty to be paid on the left, but we do get a benefit in terms of bleeding reduction of about 70% with respect to TIMI major and minor bleeding. And finally, we propose a clinical algorithm for consideration of both DPT duration and choice in relation to bleeding and ischemic risk. First, it's important to determine if a patient displays the high bleeding risk phenotype as articulated by the Academic Research Consortium. And of those patients who do fulfill that threshold, it seems reasonable to proceed with just 1 month of dual antiplatelet therapy, followed by single antiplatelet therapy, which in the majority of patients will be aspirin alone. Now, in those patients who are not at high bleeding risk, one can then consider ischemic risk based upon clinical and angiographic features. And for those patients who have neither a high bleeding risk or an elevated ischemic risk, it seems appropriate to proceed with just 3 to 6 months of DAPT followed by aspirin monotherapy, which is essentially what current guidelines stipulate. However, in those non-HBR patients who do have multiple high-risk features or present with an acute coronary syndrome and therefore at least are at intermediate or high ischemic risk, one can treat these patients with 12 months of DAPT with the potent P2Y12 inhibitor, or based on recent randomized controlled trials, 1 to 3 months of DAPT with ticagrelor followed by ticagrelor alone. Thank you for your time.